Hi everyone, my name is Taylor and I am a current student at Cal Baptist University studying health administration and management. I decided to do my critical assignment on the Medicare program. And national health insurance has been talked about for many decades. It was first brought up by President Teddy Roosevelt and later pushed by President Harry S. Truman. President Truman's plan for national health insurance was to cover all Americans for paying typical expenses such as doctor's visits, hospital visits, laboratory services, dental care, and nursing services. Truman fought to get the bill passed during his presidential term, but it wasn't until 20 years later that a form of national insurance, also known as Medicare, was implemented. Medicare was signed into legislation in 1965 by President Lyndon B. Johnson. In 2017, there were as many as 58.5 million people receiving health coverage through Medicare. Medicare spending reached $672.1 billion in 2016, which was about 20% of total national health spending. It was once thought that the rising age of the baby boomers would cause Medicare to go over budget, but billions of dollars have been saved under Medicare Part A and Part B. Medicare broadened to include those permanently disabled workers and their dependents, and those who are eligible for old age 65 years and older. It also broadened to include survivors and disability insurance under Social Security, as well as persons with end-stage renal disease. In the 1980s, Medicare began to include hospice services for terminally ill beneficiaries. Medicare is funded by Social Security taxes and by enrollee premium payments and general revenues. Medicare is run by the U.S. Department of Health and Human Services. There are four components of Medicare: Part A, Part B, Part C, and Part D. Part A covers on a limited basis for inpatient hospital care, labs, surgery, skilled nursing facilities, hospice, and home health care. Part B covers physician and other outpatient services such as durable medical equipment. Part C covers or allows beneficiaries to enroll in a managed care organization, and Part D was designed to lower the cost of prescription drugs. Recently, new Medicare cards were distributed to beneficiaries, and in the right-hand corner is an example of what the new cards look like. Some of the challenges that Medicare currently faces is financing, affordability, and managing chronic diseases. As the number of people eligible to receive Medicare benefits has risen to 10,000 people a day, the number of workers to pay taxes to help fund the program is decreasing. Another challenge is affordability. In 2013, half of all people on Medicare had incomes below $23,500 per person, and premiums for Medicare and supplemental insurance accounted for 42% of average total out-of-pocket spending among beneficiaries in traditional Medicare in 2010. Lastly, another public health challenge facing U.S. healthcare delivery systems and Medicare is managing chronic illness. It is important to keep beneficiaries as healthy as possible. Like the healthcare delivery system, the public health system is a web of relationships between many providers, hospitals, and other organizations. They all work together to keep the public healthy and provide quality care when needed. According to U.S. News, nearly half of the people on Medicare have 4 or more chronic conditions, and 10% of the Medicare population accounts for 58% of the spending. Reducing the rate of chronic disease would save Medicare a significant amount of money and improve the quality of care for patients. Chronic diseases include those such as heart disease and diabetes. An article that was published from the New England Journal of Medicine analyzed Medicare claims between 2003 and 2004 to describe the patterns of rehospitalization and the relation of rehospitalization to demographic characteristic of the patients and to characteristics of the hospitals. The rehospitalization rates of Medicare beneficiaries is fairly high and cost the Medicare program approximately $17.4 billion in 2004. Is there anything that providers can do different to lower the rates of rehospitalization? Rates can be reduced by recently proposed payment incentives. MedPAC also recommended complementary changes in payment rates so that hospitals with high-risk adjusted rates of rehospitalization receive lower average per-case payments. The high rates of rehospitalization puts the beneficiary's health and wellness at risk. This is one reason why quality improvement is so important. Providers should focus on giving the best possible care instead of worrying about the money that they will receive. Some possible changes that could occur are to reduce the cost. The managed care advantage plans have been very successful. Expanding the successful Medicare Advantage program to both Medicaid and employer-covered populations. The Medicare Advantage plan has been successful in providing quality care and customer satisfaction. The Medicare Advantage program covers more than 30% of Medicare beneficiaries. The most popular plan is the Health Maintenance Organization, or HMO format, and is administered by commercial insurers who compete on the basis of service, provider networks, and quality. As you can see in the picture in the left-hand corner, Medicare Advantage plans enrollment has grown 44% over the last 5 years. Employers would be able to offer plans through public or private exchanges. A second possible change to occur would be to slow spending growth and improve quality of care. This would be through Accountable Care Organization, which is defined as a network of doctors and hospitals who agree to work together with Medicare and share responsibility for delivering high-quality, coordinated care to patients. The first step would be finding eligible organizations. The following step would include determining the Medicare beneficiaries served by the ACO, setting spending benchmarks and cost performance for ACOs, performance measurement to promote accountability, and distributing shared savings. Shared savings bonuses are distributed only if an ACO's performance is below its benchmark. The goal would be to reduce Medicare spending and improve quality of care for beneficiaries. Thank you so much for listening to my presentation, and I hope you enjoyed it.